Okay, so I think we're live, and allow me to express a very warm welcome to all our participants. Thank you for setting aside time to join us in this webinar. The webinar is being co-hosted by APMEN and the Rollback Malaria Vector Control Working Group, and it's going to focus on vector control in compromised settings. And we're very fortunate to have three highly experienced experts in their fields to share their experiences and insights on this important topic, which is becoming more and more urgent due to the escalating climate change and political conflict consequences and other factors resulting in people being displaced into highly compromised locations and situations. There are multiple examples of that, and the trend is they're becoming more and more frequent with many people in dire situations. The webinar will be co-chaired by myself and Joseph Lewinsky. And Joe, please know we are all very grateful that you agreed to co-host this webinar. So before I hand over to you, Joe, to introduce the organization you're involved in, let me say a quick few words about APMEN. APMEN stands for the Asia Pacific Malaria Elimination Network, and it provides technical support to the 22 member states spread across the Asia Pacific region. And APMEN provides this technical support via the five thematic groups, which are the APMEN Surveillance and Response Working Group, the APMEN Vector Control Working Group, the VIVAX Working Group. There's also a Climate Change Interest Group and an Outdoor Biting Interest Group. And APMEN works very closely with something called APALMA, which is the acronym for the Asia Pacific Leaders Malaria Alliance, which is the more higher level advocacy and coordination body. So I'm going to hand over to Joe briefly to say hello and explain something about rollback malaria and its working groups. Over to you, Joe.
Yeah, thank you, Dr. Leo, and thank you to the APMEN team for organizing and for including the RBM Vector Control Working Group and our task team on vector control in humanitarian emergencies to co-host this with you. I'm sure many people online are aware of the Rollback Malaria Initiative and the Vector Control Working Group. There are three work streams within this and task teams across a number of different thematic areas. And our task team really focused on vector control in humanitarian emergencies, has been operating for a number of years, in which we are focused on three major issues, looking at expanding use and access to vector control tools in humanitarian emergencies, including looking at what new and novel vector control tools might be applied in different settings, strengthening operational research within humanitarian emergencies, and finally, documenting and sharing best practices where vector control tools are used in settings that we're often working in. So I think our priorities dovetail quite nicely with the speakers that we will hear from today. And I just wanted to thank again the APMEN group and Dr. Leo for organizing this. It's been our desire to have a talk regarding and focus within the Asia Pacific network. So it's our great pleasure to be included in this today. So thank you, Dr. Leo, and I think back over to you for some housekeeping.
Thank you for that background, Joe, and let me reciprocate by saying it's genuinely a pleasure to collaborate, with RBM VCWG, and I hope that this will happen more frequently in future. I mean, we have huge overlapping interests and audience as well. Wonderful, very important work you and your group are doing, which will become increasingly important for the guidance or experiences that you share with people. So thank you for agreeing to co-facilitate, co-moderate, Joe. I need to clarify some housekeeping issues. So I ask for another minute of your patience before we start the presentation. Please note that the webinar is being recorded and it will be made available after conclusion of the event on the URL which Wulan will place in the chat box. Wulan will put the URL where you can find it in the chat box. To avoid background accidental distracting noises, we will also mute our audience members and disable video mode. But we strongly encourage our audience members to pose questions to our speakers, and these questions will be responded to during Q&A session. So please, this is important now. Please listen carefully. Please put your questions in the Q&A box, not the chat box, please. We will not be monitoring the chat box for questions. Also, please put the name of the particular speaker you would like to respond to your question in front of your question. For example, Sergio, can you briefly outline which other support organizations are involved in refugee support in your area and what do they focus on? It just helps target your question to the person that you feel you would like to respond to your particular question. Please note that all three presentations will be given back to back, and then we move on to the Q&A session. And then right at the end of the webinar, we will have a very short multiple choice poll questionnaire so that you, our all important audience members, can indicate your satisfaction level regarding the event. It helps give us some guidance and idea how to improve webinars in future. So enough from me. I'll hand over to Joe again to introduce our first speaker. Please, Joe.
Yeah, thank you, Dr. Leo. So our first presenter today is going to be Sergio Lopez, who will tell us about the Mentor Initiative, vector control and humanitarian emergencies experience in Sudan and elsewhere. For those of us working in the kind of vector control and humanitarian emergency space, Mentor is no stranger to these discussions and leading operations research and other activities within this space. So Sergio is the Chief Executive Officer at Mentor Initiative. He has more than 15 years of managing experience across Africa, Asia, and South America, with a focus on malaria and neglected tropical diseases. And has really supported operation research within the humanitarian space. Really a thought leader in that from Mentor. He joined Mentor in 2013, served as the deputy director from May 2023, and then became the CEO in October 2024. He owns a master's in health development and a MSc in epidemiology. He has led emergency response to major crisis and managed community health worker programs in multiple countries. He has also supported large-scale MDA, mass drug administration campaigns for schistosomiasis, soil transmitted helminths, lymphatic filariasis, onchocerciasis, and has been actively involved in operation research and surveillance and the evaluation of these tools, especially as it relates to vector control. So please, everybody, a warm welcome to Sergio. And Sergio, thank you so much for kicking us off this morning.
Right. Thank you. Really, it was like really to thank APMEN and Rollback Malaria for this invite and for the kind introductions. It's true, Mentor has been working in operational research, very focused on vector control in compromised settings. So this webinar is sounded to us very, very tailored to our experience, not only to look at how we respond, but most of all, and that's where I will be mostly focused on, and how we have been trialing some innovative vector control tools in emergency settings, in compromised settings. Just to give a quick background, I hope you can see my presentation, just to confirm.
Yes, we can see.
Yes, it looks good.
Okay.
Thanks, Sergio.
So, I mean, just as a background, the context, needless to say, Dr. Leo mentioned in the intro, humanitarian emergencies have been increasing, either due to climate change, but also the increasing conflicts. And the problem that comes with it for vector-borne disease in general is that the number of displaced populations increase. Over the last decade, the number of displaced more than doubled. And of course, there's a clear overlap between displacement, um, areas where populations are displaced, and areas where vector-borne diseases thrive. Needless to say, as people are displaced, they get more exposed to vector bites, not only because of poor sheltering conditions, but also because there's a number of elements that make these populations more susceptible to disease like malaria at start, but beyond that. So what we see in compromised settings is an increased morbidity and mortality attributed to vector-borne diseases. This comes usually in a context where health systems are fragile, sometimes inexistent, and where where vector control takes even more important role. So these are as I mentioned earlier, these are the contexts where Mentor has been operating. Just to give you a quick background, even though Joe did a lot of these presentations, but Mentor has been focused in responding to emergencies, humanitarian emergencies, quite focused on vector control since 2004. And we take an integrated vector management approach, trying to target not only the different stages of vector life cycle, but also prioritizing tools that may act against multiple vector and diseases, trying to create as much efficiency as possible. So just to give you some scale of our work, in 2024, we supported national malaria control programs and other disease programs to protect over 2.5 million people, mostly through IRS and larval source management. Obviously, as we implement these activities in these settings, we have been learning a lot. It's quite challenging. And, I could list many challenges here. I think some of the presentations that come later in this webinar will provide clear examples. So let me just focus on this. As a bridge to what I really want to present is our work in operational research, and now we have been scaling up some innovative vector control tools. But needless to say that implementing activities in this context is quite challenging. Access and security at start, but also we tend to be quite adaptive in our planning and execution. Sometimes we plan for a population that 2 weeks later is no longer there because some of these populations are mobile; they run from risk. Obviously, the characteristics of these settings, either because the implementation needs to be done during rainy season, because it's an immediate response to flooding. It's not ideal for proper implementation. But aside from that, there's also some challenges with the tools in this context. We have been responding with the tools that exist, but sometimes it's not feasible due to the logistic and technical requirements that are needed for implementation of large scale campaigns. Some of the tools in compromised settings also struggle to survive. We can see a picture here of a LLIN in northern Kenya. The conditions are quite rough, and sometimes some of the tools don't last as much as we would like to. That we have been identifying as well and published on that some user acceptability issues sometimes, and really depending on the season where these interventions are done, it's not easy to implement some tools. I'm mentioning, for example, indoor residual spraying. If you are responding during rainy season, people are not very keen to take their belongings outside. So that requires a lot of community engagement as well. But most of all, I think the main challenge we have been facing is really to generate evidence and to measure the impact in this context. It's not straightforward, as you can imagine. I mentioned earlier, populations are mobile. That's the main denominator to assess impact, cases per population. Sometimes we cannot measure epidemiological outcomes. That's straightforward as that, and we need to focus on other outcomes, either entomological or even operational. Data availability is sometimes compromised as well as the settings, because health facilities stop working, health workers don't exist anymore. And of course, there are ethical issues with randomization, because not only because these emergencies are of rapid onset and it's impossible to randomize as in a normal trial, but also there are ethical issues about who gets an intervention. Some of these challenges for implementing operational research have been identified in a systematic review that is noted here, and that I recommend reading, because it showcases how little the evidence, how small the evidence exists to showcase the impact of vector control, the effectiveness of vector control, control tools in humanitarian settings for malaria, which basically means that there are only two tools recommended for emergencies response: indoor residual spraying and LLI-in, with some level of certainty of the evidence. But at Mentor, we have been looking for other alternatives, because we know these tools, they are amazing, but sometimes they don't fit the context we operate. So we've been actively looking for other tools that could complement the toolbox. And what I'll show you is some of the work we have done in terms of operational research, but also in scaling up one of these tools. And very quickly, let me tell you what we did in terms of what we did for trialing attractive targeted sugar bites. So some trials show that these tools don't exactly have the results in reducing malaria that we would like to. We trialed them in northern Nigeria, only using entomological endpoints, but observed a reduction, 98% reduction in blood-fed Anopheles gambiae and 92% reduction in Aedes aegypti during the 6-month follow-up period. The paper was published last year. It's quite interesting. It in our opinion, has to do, the results we found are quite related with some of the environmental conditions. So I recommend the reading, because it kind of somehow contradicts the results that were previously published. The next tool is similar to MR. We have been using it, in fact, quite a while, but we wanted to trial it also in a compromised context. So we did this trial also in Nigeria, and that showcased a significant reduction in positive households over 6 months as well. The results are still being analyzed, and hopefully a final paper will be shared over the course of this year. Finally, and potentially the core of this of our work in the past 5 years, I would say, is the work we have been doing with spatial emanators, spatial repellents. Let me use them both. So as you know, two spatial emanators have received pre-qualification last year. We have been working a lot with this, trialing this in different contexts. Results from Kenya and Indonesia showed protective efficacy against malaria, but we wanted to look beyond malaria, because vector-borne diseases in some of these contexts go beyond malaria. And we started with this trial in Syria against cutaneous leishmaniasis, with the first version of the tool, the Shield, which provides protection for 1 month. So we had to replace this. But it showed that Shield reduced incidence by 48%, incidence of cutaneous leishmaniasis, and also have high acceptability and willingness to pay. More recently, I mean, as recently as 2 weeks ago, we published this trial in the Lancet Infectious Diseases, assessing the effectiveness of the second generation of the tool against malaria in camps in northern Nigeria. So basically, we did a randomized controlled trial in 24 camps in Maiduguri, and show that, the results are in the next slide, and show the reduction in incidence of malaria, but also a reduction in indoor blood-fed Anopheles gambiae that was reduced by 94%. Similar to the Syria trial, we found high acceptability and even willingness to pay for the tool. The full details can be consulted in the Lancet Infectious Disease, and obviously I'm open to provide any clarifications that are needed. I'm going very quick because what I wanted to show as well is that some of these tools, in fact, the evidence is there. But beyond that, the tools are quite tailored to compromise settings. What we have seen with spatial repellents that they are easy to use, easy to distribute. Distribution can take days, and logistically much simpler. So what we have been doing is trying to scale up these tools in the context where we prove that work, these challenging contexts. And after this trial in Syria, we scaled up distribution to 100,000 units in IDP camps in northern Syria, again with high acceptability. And we are now trialing some private sector distribution models. Hopefully, during the course of this week, we'll learn about that as well as the context in Syria is changing. Malaria-wise, we have been also scaling up this in South Sudan in 2 camps, Jamjang and Reng. Not only because the conditions to implement this tool exist, so there's some coverage of LLI as mentioned in the WHO recommendation, but also because the needless to say what happened last year, but there was a clear need of providing some sort of protection to these populations. So we conducted a distribution in these camps where malaria is still the main cause of morbidity and mortality, and distributed over around 74,000 units of Guardian. What we are learning, in fact, is that mostly about the number of units that are needed either per household and per room. We thought it would be much less. So this is the kind of learnings we are compiling and hopefully reporting later in the year. We also did a coverage evaluation survey after this distribution 1 month before to look at coverage, of course, and use, but also to look at some of the perceptions. Interestingly, seems like the distribution missed roughly 10% of the population. But we wanted to look again if the number of units was adequate for the room size, because that's the key point about these spatial emanators. It needs to be tailored to the room size and not the number of people living in the household. Briefly, nearly 80% of the rooms had the right number of spatial repellents. Of those that didn't have, 80% had more units than required. Again, learning how can we improve the distribution of these tools so that there's no overuse, but obviously there's no under allocation of tools that jeopardize protection. Last slide. Basically, when we looked at the perceptions, and again, this is 1 month after distribution, even though we did a lot of communication about how the tool works, a lot of people still refer that they didn't find any reduction in mosquitoes inside. The spatial emanators, they may kill as well, but their main role is to confound and mosquitoes so that they bite less. And this is one of the key messages we need to continue to pass to communities. So in brief and to complete, vector control in these settings is quite hard. It's also quite hard to do proper research in these settings. But it's key that we look at new tools that are emerging and look at the timelines it takes from getting the evidence to scale up, because as mentioned earlier, the number of displaced, the number of crises is increasing, unfortunately, and these populations are in dire need of some sort of protection. And some of the old tools that are still very effective not always aren't always suitable for the context we find. last but not least, just acknowledging all people involved, and a special mention to our colleague Ramona, who passed away recently, and was key to implement all these trials that were mentioned throughout the presentation. Open for clarifications later on, and thank you once again for inviting us to present some of our work. And I hope it was useful for all of you. Thank you.
Yeah, my goodness. You said you hope it was useful. I think it was very, very useful, Sergio. Fascinating, highly informative presentation. So I think from all of us, a very sincere thank you for putting that presentation together. I must confess, I was not aware of the extent of the research that Mentor Initiative is involved in. Very, very important research on innovative, relatively new tools, ATSBs, attractive targeted sugar baits, and also the spatial emanators. Very important work that you are doing, and in a particular setting that the normal research programs don't normally operate in. So very important findings that it seems you are publishing. Congratulations and well done, and thank you again, Sergio. So we now
Thank you.
move. I'm sure there are going to be questions for you, Sergio, but let's leave that for Q&A session. As a reminder to our audience, please, we invite you very fervently, please pose questions to our presenters, but please put your questions in the Q&A box, not the chat box, in the Q&A box. And ideally, if you have a question, put the name of the presenter that you would like to respond to your question. Put it in front of your question. For example, Sergio, da 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 da, and in the Q&A box. So we're now going to move on to our next presentation, which will be by Dr. Moore on the topic of supporting cross-border displaced people along the Thai-Myanmar border and the challenges to providing vector control and other healthcare interventions. Dr. Moore is a highly accomplished senior health coordinator of the International Rescue Committee, the IRC, with a distinguished 30-year career in public health and humanitarian response across Southeast Asia, specializing in complex refugee and migrant health settings. She currently provides leadership, supervision, and oversight of integrated primary healthcare projects for IRC in Thailand, focusing on refugee and emergency response projects along the Thai-Myanmar border, which is a problematic area for various reasons I'm sure she's going to refer to. Holds a Bachelor of Medicine and a Bachelor of Surgery degree, and also a master's degree in public health from Mahidol University in Thailand. Thank you so much for participating in this webinar. We look forward to your presentation. Over to you.
Thank you very much for your nice introduction. Can you hear me well, or can you see my share slides?
See it perfectly and hear you very well.
Thank
Please
you.
proceed. Yeah.
Thank you, Dr. Leo. Yeah, thank you very much for your time and you are with us. On behalf of IRC Thailand, International Rescue Committee, I would like to share our services, our support for the displaced community along the Thai-Myanmar border in 9 temporary shelters. Our main donor is PRM, and for the malaria intervention, our donor is Global Fund. I would like to share the outline of my presentation. First part is I want to share the situation and service provision highlights in 9 temporary shelters, what we did and what we are doing for our refugee community. Second part is the malaria situation of Thailand, and then assessment of surveillance system in the 9 temporary shelters. Temporary shelters and IRC implementation area. So there are 9 temporary shelters along the Thai-Myanmar border. You see here is the many forests and jungle area that camps are located among them. And total population in the 9 temporary shelter is more than 100,000 population. And then those camps are located in Tak, Mae Hong Son, Kanchanaburi provinces. And temporary shelters host Myanmar refugees, and they forcibly migrated and moved to Thailand because of political instability, violence, and some conflicts. That area is very remote and very difficult access to services, livelihood, and mobility. So the resulting long-term displacement, isolation happen. Okay, what we provide, what we are doing in the camp. IRC and our partner agency, we support refugees for many decades, and we provide humanitarian assistance address for immediate needs and long-term resilience. For IRC, we provide a primary healthcare and reproductive and child health services, environmental health. We also have the protection program and women's protection and empowerment, economic recovery, development, and livelihood. I will focus mainly for health and wash activities. Okay, in 9 camps, IRC, we provide our services in 7 refugee camps. So I can mention the name of the camps. Mela Nupo, in the Tak province, there are 3 camps, Mela Nupo Ompiamai camp. In Mae Hong South, you see here the 2 camps, Bamanan Swai and Bamansurin camp. In Mesaria, you see the logo of Marisa International. That is another international NGO. They provide health and wash services in that 2 camps. Kanchanaburi province, Rajpuri province, some camps are located. That is the Tamhi and Banoyang camp. So our health service provision, health and wash service provision is very, very unique. So who are the service providers? For our refugee people, camp-based assistance, actually they are part of refugee community. And then we selected for the eligible refugee people, and IRC under the capacity building program, we conducted several kinds of training to enhance the skill and knowledge of CBA. So we train many CBAs, we assign them in the different departments. So like medic, nurses, midwife, laboratory staff, environmental health workers, and mental health workers, they are working in our health facilities. Health facilities, this is actually the different kind of health facilities. That is depend on the size of the population. And for example, in Mela camp, population number is very high, more than 35K population. They are temporarily still in the Mela camp. So health facility is about 155 bed hospital. Smallest camp is located in Kanchanaburi. We call Banoyang camp. That is only 12 bedded hospital. So what we are doing in the camp? So like other hospital, we ran the OPD, outpatient department, inpatient department. So I want to explain a little bit about what we are doing in the daily outpatient activities. In the department, we do the consultation for the communicable and non-communicable diseases, including mental health cases. We also have 24-hour inpatient department, inpatient ward. So for the unstable patients, we keep in the hospital, and service providers are, as I mentioned, camp-based assistant. They monitor the patient. In case of emergency, for the complicated cases, they transfer the cases to hospital. So IRC, we provide referral services, transportation, and then also interpretation, counseling, and also we also cover the referral costs in the hospital. SRH, Reproductive and Maternal and Child Health Program, is another program that is also very important for our service provision. We provide trained midwife. They provide antenatal care service, postnatal care service, safe delivery. After delivery, informed family planning, counseling is very important. And after counseling, we provide short-term, long-term contraceptions. For the complicated cases, as I mentioned, we can transfer the case to hospital. And we also have the small newborn care unit, baby care unit, to take care for the low birth weight baby and then some ill cases. Routine immunization is a very crucial for our program. We received vaccination from Thai authority, and we follow the Thai EPI guideline and protocol. And in the camp study, cold chain is very crucial. We need to collaborate effectively, and we need to get the support from the different stakeholders. Not only curative, preventive service is also very important. So who are the service provider for the preventive care? So you see here, disease surveillance, outbreak control, health promotion campaigns, health education activity, and to conduct the home visit. We have a community outreach team. CHW, they work in the field closely with the community. As I mentioned, our people, they know very well about their community. So they know the approach, how to approach their people. So we have to conduct a different kind of campaigns. Our focus is not only for the communicable disease, non-communicable disease like hypertension, diabetes, epilepsy, thyroid, including mental health. So we need to conduct the regular home visit. One thing is home visits is not only tracking the patient, not only follow up the patient, not only the checking the compliance, drug compliance of the patient, we also need to record the demographic data. We want to see the population movement, and then also we need to get the accurate denominator for our service. So CHW, they work closely with the camp leadership, and they are in the field, they collect the data regularly. Provision of the safe water supplies, environmental sanitation, waste management, weather control, hygiene promotion, infection prevention controls are quite essential under environmental health program. Our trained environmental health workers, they work closely with the CHW community outreach team with the support of the Thai authorities. At the time of outbreak, they are really working in the field and set up the many meetings, and they try to conduct the many campaigns and preventive activities. Mental health is another important part for our program. So not only giving the treatment, if we see the mental health cases, so our trained mental health workers, they know the early warning sign of the mental health problem, kind of depression, anxiety. They work in the field. And then also we provide counseling, individual counseling, group counseling. They track the patient at the home, and they need to do the counseling with the family members. And psychoeducation, relaxation activity, and to form the support groups are very important for our program. So if we see the very complicated cases, we transfer the case to hospital to get the treatment from hospital. That is quite challenging to handle the mental health patients, and also community participation is very crucial for us. What happened in 2025-26? That slide shows I would like to share our IRC situation. In 2025, globally, that is that we face many issues. In January 2025, US government issued the major stop work order and family freeze happened. So at the time, IRC, we have to focus only for the emergency life-saving services. We have to suspend many activities like health education, health promotion. Depend on the donor requirement, we have to adjust our service implementation strategy and program instability, and also that response. Serious uncertainty for the program happen. We have to plan immediately. We have to strengthen coordination, and also we have to change our strategic plan, reclassify our role and responsibility of the staff. we have to brainstorm for the risk analysis, and we have to prepare for the mitigation plan immediately. Our goal, our objective is to do service implementation and smooth transition. 1 minute. What we are doing currently, I want to explain a bit about the current ISC activity. I mentioned our main donor is PRM, but we also have some small donor like a JICA. So at the moment, IRC, we are doing the capacity strengthening of the refugee workforce. So refugee workforce is not only our campaign assistant, we also work closely with the other ethnic organization for the to enhance the skills and knowledge of the migrant head workers. So that is under the JICA, that is pilot project only for the TAC province. We work closely with the Border Health Learning Center. It is located in the one border hospital called MESA, and the other district hospital and provincial head office. We contacted many trainees for the border health system strengthening and integration. Our goal is the refugee workforce recognition in the future. We would like to advocate for the certificate accreditation for our refugee workforce. At the same time, we would like to strengthen for the smooth transition to the local authority for our head and watch services. For the second part, I would like to explain a bit about our malaria strategy, Thailand National Malaria Strategy, and assessment of surveillance system in 9 temporary shelters. Out of 77 provinces in Thailand, according to the National Malaria Strategy, you can see different color, green, yellow, and 8. So 49 provinces are yellow, green provinces. Strategy is prevention and re-establishment. 20 provinces is red yellow, strategy of elimination. You see 8 provinces that is under red category. So we need to do the outbreak response aggressively in 8 provinces. Our 9 temporary shelter located in the red 4 provinces. So we have to do the aggressive malaria intervention activities in the camp. What we are doing. So I want to explain a little bit about our activity, surveillance system strengthening. So we have a guideline for the border refugee community that is called Guideline for the Disease Surveillance. That is developed by BOE, Bureau of Epidemiology of Ministry of Public Health, and with the support of the other service implementers, we have clear guideline. We have to follow threshold and then a reporting system of that guideline. We have weekly outbreak alert reporting system. So we need to report for the 14 diseases. Malaria is one of them. Many thresholds. We have to refer to the many thresholds, like last year threshold, last 3-year, 5-year threshold, and then we have to open the outbreak depend on the situation. Another information, another reporting system is the UNHCR IRHIS system. That is not only for the communicable disease, other diseases, different department, different disease pattern we need to report regularly. Rifle E program activities in Thailand. I want to explain a little bit. That is IRS indoor residual respiratory activities under the better control. We used to conduct 2 times per year for all 9 camps. And then another thing is LLI and distribution. Another one is just the case management. And then education activity is very important. For the 137 strategy, that is still practicing in the camp setting, within 1 day, we have to do the case notification. We have to report confirmed malaria case immediately to the different level, from the district level to the provincial and national level. That is a warning alert system. Within 3 days duration, case investigation is ongoing. Conduct a case investigation. Whether case was important or contracted locally. That is very important. And our CBA, they all are trained how to fill that case investigation form with the support of with the guidance of the BRDDC. And we have to do the regular reporting. And within 7 days, this is a case response. Sorry. Case response is just like for the case classification and area stratification. Okay, IRS activity. When we conduct the IRS activities, that is very important, better control activities. So as I mentioned, twice per year, this year we have already planned. We used to conduct the IRS spirit activities before rainy season and after rainy season, twice per year. You can see the like our camp-based assistant, they are doing the IRS in the refugee camps. You can see the housing condition of our camps. LLI and distributed activities is very important. Started from 2022 until now, we are doing the LLI and distribution for this year. I think in TAC camps that now still ongoing. You can see the figures here clearly. For the rifle program activity, another important one is case management and case detection strategy. So passive case detection, PCD, reactive case detection, RACD, and PACD, proactive case detection. With the support and with the guidance of the BRDDC, we have to manage effectively for the malaria suspected cases, and also mass screening or RACD, PAC, depend on the budget, depend on the situation. Their protocol is just that used to adjust and also they updated. Follow up is very, very important because especially for the PV cases, for the mobile population, that is very difficult to follow up, and also they need to finish all course of the anti-malaria medication. All positive cases are treated according to the Thai national treatment guideline. Health education, health promotion, changing the behavior. That is very crucial for the malaria elimination. So we used to conduct health education activity in the health facilities, in the community, and also like the school. That is, we used to conduct the activity together with PACD, RACD, and LLI and distribution activities. That slide, I would like to explain a bit about our malaria positive situation cases in 9 laboratory shelters from 2022 to 2025. You see here nearly 6,000 malaria cases are reported within the reporting period from 2022 to 25. 2022-23 cases are very high, nearly 2,000. So what about the high peak season? So I want that is same for everywhere. Rainy season, so that you can see the graph. This is a case of this high. We also need to track the information of history of traveling, because that is very important. This is the locally transmitted case or imported case. So history of traveling, yes or no, is one of the important points. Within 14 days, 57% of case has a history of traveling to Myanmar. Another 43% has history of traveling outside the camp. So only Thailand, maybe that they get out from the camp and also they stay they visited to the other area. And if we see the type of parasites, Plasmodium virus is very high, up to 90%. In 2025, we also some PF positive cases are reported. I think about 20% cases are reported in 2025. If we see the age group, most of the cases occur among individual age over 18 years, percentage of 43%, followed by 5 to 70 years age group, percentage show 35%. If we see the gender, male is 72% and female is about 28%. I want to draw the attention about challenges and recommendation for the audience. Okay, challenges is a budget reduction and limited resources. So this affect for the case management, BACD, RACD, IRS, and LLI distribution, as well as for the supervision and monitoring. That is also very challenging for us. And then community engagement, very important. Limited community engagement. and also motivation among the community is very crucial. So somehow it is negatively impact on prevention and control activities. Bora instability and population movement is very challenging for us because to track the patient, follow up the patient, and also to check the drug compliance issue. That is somehow, sometimes it is the patient just, stay in the house and then move out from the camp. They also need to work, and then they visited to their friends like that. And then IRC service transition in 2025, as I mentioned in the previous slide. We no more direct service implementation by IRC with the program downsizing. And so we need to formalize, we need to strengthen to formalize the coordination mechanism and funding body with the Thai Ministry of Public Health. Our recommendation is we need to strengthen community participation and ownership. That is very, very important to ensure long-term sustainability, to eliminate malaria. And then capacity building of the P staff, program staff, camp-based staff, campaign assistant, that is very important. Monitoring evaluation is very crucial. So why not to utilize the technology, new technology, and then also we can train to our staff, including camp-based staff. Somehow it will be very useful for us. We also need to strengthen cross-sectoral coordination with the key stakeholders, including Thai authorities, camp leadership, local CBO, CSO, and including ethnic health organization. We should not forget to maintain, to keep on doing effective advocacy to get the funding and also support from the donors. Meanwhile, we should not forget to optimize the resources and to prioritize our key activities. Thank you very much for your time. And also I'm really happy and also for more clarification. Yeah, I want to stop here. Thank you very much.
Dr. Aya, thank you so much. A wonderful presentation. Yes, so much information about what's happening and what IRC is doing. It's really incredible. So thank you again. Just to reiterate Dr. Leo's points, for those of you who have questions for Dr. Aya, please put them in the Q&A chat function below rather than the actual chat, and we'll get there. So Dr. Aya, thank you again. So it's my pleasure to introduce our final speaker here, Dr. Mohammed Mokhtar, a friend and a colleague who I've known for a number of years. And so Dr. Mokhtar, we're incredibly happy to have you here from Pakistan, who is going to share some of his extensive experience on the topic of addressing multiple challenges in vector control following extreme flooding events in Pakistan. Many of you may have heard Dr. Mukhtar speak to this before, but it's always an enlightening and a very interesting conversation. So Dr. Mukhtar is the director of the Directorate of Malaria Control in Pakistan. He's worked in the field of medical epidemiology for the last 25 years, has extensive experience in development of national strategies for vector control, and of vectors of other public health importance, which we know are present in Pakistan. Examples of his strategic thinking and expertise are evident by his authorship of the Pakistan National Plan of Action that runs until 2028, and for the sustainable management of vector-borne diseases in Pakistan. These include a number of different issues related to climate change issues that Pakistan has experienced, which I think Dr. Mukhtar will speak to today. And most recently, he developed the country's first national policy framework for preventing vector-borne diseases and climate-driven humanitarian emergencies from policy to implementation. So yes, just an incredible wealth of knowledge, and we're very lucky to have him. So Dr. Mukhtar is also the current chairman for the APMEN Vector Control Working Group and has a role he has fulfilled professionalism, and I think many within our community know him. So Dr. Mukhtar, over to you for your presentation, and thank you so much for taking the time to join us today.
Thank you. Can you see my slides?
Yep, perfect. Just put them in
Yeah.
presenting mode. Yep, perfect. Looks great, Dr. Mukhtar. Thank you so much.
Very good morning, good afternoon, good evening, according to your time zone. This is Mohammad Mukhtar. I'm Director, National Malaria Control Program, Pakistan. Please, if you don't mind, I turn off my video because there is some instability in the connection. So please don't mind it. Yeah, my title of the topic is the vector control under extreme flood situation in Pakistan. Today, I will share the vector control after the extreme flood in Pakistan, highlighting the challenges, responses, and the lesson from the recent humanitarian emergencies in Pakistan. I will cover how the vector control operations like IRS, ITN distributions, which were affected, the emergency adopted strategies which were implemented, and finally the key lesson learned. These experiences shows that post-flood outbreaks are driven less by the lack of effective tools, but more likely by the operational and constitutional and the context-specific challenges. Can I move to my slide? Oops. Yeah, this is my agenda for next 15 minutes. Yes, why this topic is matter globally. We all know that the vector-borne diseases cause more than 750,000 deaths every year and account a significant share of the global infectious disease burden. Over last 4 to 5 decades, climate-driven humanitarian emergencies, specifically flood, have become more frequent, expanding vector habitats and increasing transmission potential. During emergencies, the risk of the vector-borne diseases can increase up to 5 times. While presenting Pakistan as a case study here for a low and middle income countries, I'm sure that similar changes are also, I'm sure that this is not a Pakistan specific issue. Many countries, countries in Africa, of Asia, are in fragile setting are facing the similar challenges. Even the advanced regions like Europe are also now facing the increasing problem of Aedes-borne diseases. In Pakistan, why we focus the extreme flood. Extreme floods are a critical focus because Pakistan faces a regular large-scale flooding that has become more frequent and intense due to climate change. Flood rapidly changes the vector ecology, creating the widespread stagnant water, breeding sites, and increase the transmission potential. At the same time, displacement of population and their disruption of the health system weaken the routine disease efforts. As a result, secondly, the disease outbreaks, particularly malaria, often follow the humanitarian emergency disaster with impacts that extend well beyond the immediate flood period. Humanitarian emergencies fundamentally disturb the environmental, creating the widespread stagnant water and damaged infrastructure that favor the vector breeding. Displacement places a large population into the overcrowded shelters with the limited physical protection, while they significantly increase the human vector contact. At the same time, routine vector control activities such as IRS, ITN distribution, and larval source management are interrupted or suspended permanently. Surveillance and disease early warning system weaken, delaying the outbreak detection and timely response. These overlapping failures accelerate the vector breeding and intensify the disease potential, particularly for malaria and other vector-borne diseases. Now, I will specifically talk about the floods in Pakistan. Pakistan facing the unique floods in 2022. And even in 2025, there was a huge flood in Pakistan when a country received almost 200% increase in rainfall particularly the two provinces, which are already highly endemic for malaria. And almost 65% of the country was affected by this flood, and almost 30 million people had to live in the temporary shelters. Almost 2,000 people, including 650 children, died. Around 2,000 health facilities and 13,000 kilometer roads and 450 bridges were damaged, cutting off the access to the essential services. These conditions triggered a sharp surge in the malaria, leading a national state of emergency, the heaviest resurgence of malaria in the last 5 decades of the country. And you can look at the number of cases in 2021, we have only 375,000 cases, but after the flood, it jumped from 300,000 to 3 million. And even in 2023, it was 2.9 million, and 2024 is a 2.6 million, which shows that there are consequences of the flood of 2022. But even in 2025, we again have a very massive flood in the country, which further worsened the malaria situation and vector-borne disease situation in the country. What are the operational challenges which we are facing in Pakistan due to flood and other natural calamities? Particularly, this slide shows that how the climate shocks can rapidly reverse the vector control gains when the system are not disaster resilient. This slide highlights that extreme flood in Pakistan severely disrupted the planned vector control activities, including IRAS and ITN distribution campaign. Large-scale displacement, about 30 million people, of which the 60% were living in temporary shelters like school tents, further increased the malaria transmission risk. In 2022, we have a national campaign where we plan to distribute 6.2 million mosquito net, which was heavily impacted due to this flood. Overcrowded and unsuitable shelters limit the effective use of the nets, and many tents were too small to accommodate the standard rectangular ITN. The key message over here is that yes, we have provided the bed net to all the affected communities who are living in the temporary shelters, but unfortunately the community was unable to use those bed nets just because of the space constraint. You can see the shape of the tents. It was not suitable to accommodate the rectangular bed net in the such settings. That's why despite the fact we have distributed the 6.2 million mosquito net, almost 100% population got the bed net, but unfortunately due to these constraints, space constraints, they were not able to use those bed net effectively. Then supply chain were damaged, resulting in the delay in distribution of the distribution and loss of ITN and essential materials. So combined these challenges, restriction was also a very big issue during this flood. Restricted access to the flood and remote areas prevented the timely delivery of the intervention. Together, these operational challenges significantly contributed to the sharp rise of malaria cases across the affected countries. Here, the key message is that post-flood outbreak is not due to the lack of effective tool, but rather due to operational breakdown that prevent these tools from being delivered when and where they were most needed. And this is just a slide shows that how the problem was there during the flood, that we have almost 6.2 million mosquito net from the Global Fund, 2 million mosquito net from government side, and 2 million nets from the other donors like UNICEF, and the WHO also provide a lot of supplies for the affected communities. But just because of the majority of the essential supplies were not reaching to the affected area due to severe damage to the road infrastructure. This disruption in aid distribution escalated the emergency, leading to another wave of humanitarian crisis in Pakistan. So these are just big challenges which we're facing during the flood in Pakistan. No, what works in well? Now, what are the implementing strategies in Pakistan? We are doing this. Emergency adopted integrated vector management were adopted in a specific construct in a this scenario, that when there are the limited resources, when there are some other issues was there. So Pakistan adopted an adoptive integrated strategy for ITN distribution in response to the post-flood realities. 13.5 million ITN nets were distributed free of cost through Global Fund support and by other partners and government. Campaign nets were also integrated into the relief and food packages to ensure the rapid reach to the displaced population. A key lesson learned by that the stagnant, as already mentioned, that the standard rectangular nets were often impracticable as the nets were too small for proper installation in the tents, particularly, and other places where that due to the space constraint. Similarly, temporary shelters were overcrowded to install the ITNs by individuals. More important, additional nets were also, but this is a plus point, that the more nets were provided to, sorry, I was over here. More nets were provided to the affected communities when they were returning to their homes, because when they were living in the temporary shelters, many people lost their bed nets. So the additional mosquito nets were provided to the household when they were returning to their homes, maintaining the protection during the recovery. Local procurement is very important, which we are always support, that the local procurement can further strengthen the response with the Pakistan leveraging its large WHO pre-qualified ITN manufacturing capacity to ensure the timely and cost-effective supply. So these are the adaptive strategy for the IRS, for the ITNs. But for this IRS, we have also very big campaign for IRS, that emergency adopted integrated vector management enabled the rapid IRS deployment in the unstable and resource limited setting. Short-term strategic plan was developed, prioritized the emergency preparedness and response in Pakistan. Targeted IRSs focus on the high-risk areas, accessible sites, temporary shelters, living room, and animal sheds. Risk-based target optimized use of limited insecticides, spraying equipments, and the trained staff. I just give you the example of one district where the rapid IRS implementation led to immediate reduction in the transmission in the flood-affected district, like the Larkana district, where the test positivity rate reached to 58% post-flood to 10% within 1 month, with the rapid IRS implementation in a very, very specific manner after the proper training of the staff. So this shows that the strong that the IRS is one of the core intervention to bring down the caseload immediately in Pakistan, when the one district was reached more test positivity rate more than 58%, and it just dropped down to 10% just within 1 minute. On top of all, strong coordination among all the partners, among the district health authorities and other partners like WHO, UNICEF, to ensure the quality and coverage. I've already explained this one. Other tools. Community-led larval source management rapidly reduced the breeding site where the routine interventions were disrupted. Fogging, although is not recommended as a routine intervention for malaria control, proved a useful during the emergencies by rapidly reducing the adult mosquitoes' densities and ensuring the public confidence. Special repellents and insecticide-treated clothing provided an immediate practical protection for the displaced and mobile population. Altogether, these intervector tools. These tools implemented IRES and L Alliance, and they strengthened the overall vector control during the flood response. Yes, and in long-term planning, countries develop a national framework in response to this complex and evolving threat. National Malaria Control Program developed its national framework from policy to practice, a national framework for preventing the vector-borne disease in climate-driven humanitarian emergencies. It is actually built on our National Plan of Action for Vector-Borne Disease from 2024-28. This frame recognized as an urgent need for the comprehensive, multi-sectoral, and climate-informed strategy to strengthen the country's capacity to prevent, detect, and respond to the vector-borne disease in both routine and humanitarian emergencies. It is grounded on the One Health approach and aligned with the global commitment, including the WHO's Global Vector Control Response, the CNDI framework for the disaster risk reduction, and the SDGs. So countries develop a long-term planning using its experience of the handling the not only the flood of 2022, but also the earthquake, some other natural disaster in the country. So at least country has now something in its pocket, a very concrete document how to handle the situation if the similar situation arises in future. It's a message, is a national call to act to reduce the vector-borne diseases. Emergencies intensify, no doubt, and emergencies intensify the vector-borne disease risk. Vector control is not a luxury in the crisis, it's a life-saving intervention. Standard vector control must be adopted community-oriented, flexible approaches. We can build a future where our health systems are resilient, our communities are protected, and the impacts of the climate change are no longer a threat to the right to the health of every citizen of Pakistan. Let this be our collective legacy, a stronger, smarter, and more equitable health response for the generation to come. The lesson from Pakistan can apply to many humanitarian settings globally for effective management of vector-borne diseases. So these are the key messages which are from the top level of Pakistan Minister of Health and Secretary of Health, that after having facing the experience of the flood of 2022, 25, and other natural disaster, country developed its national framework to manage the sustainable management of vector-borne diseases under humanitarian crisis. I think these are our strengths. We are thankful to our partners, National Disaster Management Authority Pakistan, Global Fund, APMEN, Malaria Consortium, APALMA, and other UNICEF and MMV, and some other private industries who are really powered behind the National Malaria Control Program Pakistan. Thank you very much.
Dr. Mukhtar, as always, a very powerful presentation crammed with, tight, concise points, solid information, which reflects the many, many years that you have behind you leading vector control operations in Pakistan, not just malaria, but also arbovirus vectors, leishmaniasis, all of those have been your responsibility. And although you didn't mention it, that national guidelines, you were the senior author of that, capturing all those years of experience, and particularly the extremely valuable lessons that emanated from the floods. It's very unfortunate that Pakistan suffered that event, but you were able to extract maximum lessons from that and capture it in a document that serves as a guideline, an example to other countries of how they could, in an emergency situation, go about dealing with these situations. So I think from all of us, sincere thank you. So we are now going to move to the Q&A session, which in many ways is perhaps the most useful, I mustn't stretch it that far, but it's a very valuable element of the webinar where the audience has opportunity to pose questions to the panelists. So Joe and myself are going to extract questions from the Q&A list. We are not going to have time, unfortunately, to go through all the questions. So we will extract questions that we feel are not of very narrow, specific interest, but perhaps have broader value for a greater number of people in the audience. So, hopefully we will get to each of your questions, but we're going to try and focus on questions that have broader impact and value for a bigger number of people. I'll start off with question one to Sergio. Joe will then extract a question for Dr. I will do one for Dr. Mukhtar, and so we'll alternate in posing questions to our panelists. So let me go to the first one that I could extract that was directed at our first speaker, which was Sergio. So the one I have here, the question, Sergio, was how can the spatial emanator be implemented for outdoor biting mosquitoes? So, I think the broader question is, did you confine the use of spatial emanators to indoor situations? Were you able to also apply them outdoors? And what was your impression about the effectiveness of spatial emanators and the outdoor situations, which is where a lot of the residual malaria transmission actually occurs? Do you have any insights about outdoor transmission and the benefits, potential benefits of spatial emanators under those situations? Thank you, Sergio.
Well, thank you for the question. I think it's one of the many questions that arise in terms of research on spatial emanators, outdoor transmission, the role of spatial emanators. So the straightforward answer to that question is no. We just assess indoor behavior, so that's straightforward. I remember in ASTMH 2 years ago, if I'm not mistaken, there was a group doing some assessments in outdoor kitchens in Zambia and in Papua, if I'm not mistaken, with mobile populations and their shelters that have no walls. And they found some interesting results in terms of reduction in malaria incidence. But I think one of our follow-up questions or studies that we are in fact trying to implement is to look first at the peridomestic results. Now, spatial repellents, it's a new class of vector control tools. All entomological procedures, I would say, may not be the most adequate. If we're talking about indoor resting behavior and so on, if we're talking about a tool that more than killing, and that was one of the questions, so just trying to address two in one. More than killing, it also has an effect in confounding the mosquito. So they're still alive, they're still there, they just bite less time. So I think the main question is what entomological endpoints are we measuring to evaluate the effect of spatial repellents on one side, and how then that is translated to measure outdoor or residual transmission. Because I understand in some contexts, like particularly in Asia, it's a major issue, but also we see that the vectors changing their behavior in Africa. And there's a big research question about how to measure the impact of spatial repellents on outdoor transmission. So yeah, just a broader answer, but the straightforward answer is we only assessed indoor behavior.
Wonderful. No, excellent. I mean, we can hold a webinar just on that topic by itself. So it's a big topic. Thank you for that concise, good answer. Thank you, Sergio. Joe, are you able to extract a question for Air?
Yeah, Dr. Leo, of course. Dr. A, there's a number of different questions in here, so I'm going to try to combine some. There's a number of people who are interested to hear a little bit more about the 137 approach that you talked about and some of the adaptations that are needed given the current context. So I think the first question related to it is asking do you do you all have the appropriate resources needed to respond within that 7 day time frame that you discussed, especially given the current context, and a bit about the pre-positioning, especially of IRS. That might be needed as the potential response within the cases that are seen. So if you could, speak to that at one point. And the second part of that question, if I could ask it, is uh, the coordination that's often needed between the Thai government, and IRC. Has that changed at all in terms of implementing that 137 approach? So I think one related to the kind of pre-positioning of materials and resources available, and two, any changes to that kind of coordination with the government itself.
Thank you very much for the questions. Yes, that is really very, very important and to keep our proper cooperation with the Thai authorities. As I mentioned, our IRC main grant is the BRM. Because of the stop work order, we have to prioritize only the emergency life-saving services. It means kind of the health education, health promotion, and community mobilization activities are somehow not in the prioritized list. So it is related with the malaria intervention activities because our community outreach team members, they work closely with the malaria workers across 7 camps. To implement the 137 strategies, we have to rely on that Global Fund budget. So for example, IRS, we use the bifenthrin, and then we receive the proper support from the Global Fund. And then we need to deal with our local authorities, Department of Disease Control and local BBTC departments, in case and that we can request from them. That is not related to the BRM. So we follow the 100% for the all positive cases for the 137 strategy. So when we receive the report from the clinic, from the medics, they inform to the outreach workers, and also they inform to the environmental health workers. So we do the IS bearing, and that is for the index house and about 50 meters radius surrounding 10 households. We do the IIS spraying. That is not much IIS spraying. If we see the positive case, we strictly follow the instruction of national Thai national guideline, and then their instruction. That is one of the indicators for us. Yeah, thank you.
Yeah, great thing. So I think important in the kind of current context and climate that we look at the different donors and what they're funding and trying to coordinate activities across those. But it's great to hear that the kind of operating procedures that are required by the Thai government are still being able to be followed, given the kind of current context and climate. So thank you for that. So Dr. Leo, over to you, I think, for Dr. Mukhtar.
Yeah, thank you. Thank you, Joe. So Dr. Mukhtar, to you, if you don't mind, this was a question that did not specify a panelist, but my intuition suggests that you are perhaps the best position to respond to this question. And the question was, we are fighting vectors for ages now, and vectors are genetically modifying with all the efforts of control. But then the key element in this question is, in Ethiopia, climate change is playing a big role in reversing the gains made in the last 10 years. So in relation to climate change and its consequences, don't we need to change our strategies So would you mind giving us a little bit of, I know you have a very strong interest in climate change aspects. Would you mind just spending a minute or two giving us your perception and interpretation and opinion on the importance of climate change and how governments should go about responding to it? Is there anything that the Pakistan government is already doing to incorporate these climate change challenges into national policy or strategies? Over to you, Dr. Mukhtar. Dr. Mukhtar, I'm not sure if you.
Sorry. Thank you
Yeah.
very much for a very interesting question, and it's very important. And I think this is nowadays a very important question globally. In Pakistan, particularly, yes, you know that the Pakistan is the fifth most affected countries, while our greenhouse gas emission is less than 1%, which means that we are paying the price of the deeds which we are not committed. But in Pakistan, yes, of course, the government is very, very sensitive for this issue. And Pakistan is, I think, is one of the few countries which has a full-fledged, a regular Ministry of Climate Change in Pakistan since 2012. Early, we have the 2012, since it was established the Ministry of Climate Change in response of a massive earthquake in 2005 when there was a need to have some ministries. So Pakistan developed its Ministry of Climate Change in 2012. And with the passage of time, this Ministry of Climate Change was upgraded, was modified in view of our recent natural calamities like the floods. And even after the flood, we have in our National Disaster Management Authorities, which is actually the part of and Pakistan has one of the best disaster management authority, not at national level, even at the provincial level and the district level, what we call provincial disaster management authority, national disaster management authorities. So climate change is a very sensitive issue in Pakistan, and there is a very good response from the government of Pakistan having a full-fledged ministry, then different departments, and then national plan of actions to mitigate the impact of the climate change in Pakistan. In long term, I saw one very interesting question, which is can be the part of this question, that how we can reduce the frequent flood in Pakistan as a consequence of the climate change. Yes, it's a question which always asked by the local media, by the politicians, that how we can stop these regular floods in Pakistan. Yes, to build the dam, to strengthen our big infrastructure. You know that Pakistan has the largest canal irrigation system in the world. But just because of the delay in the construction mega dam, in the need of the climate change, we are facing the regular consequences of the climate change in the form of the flood. So now government is very sensitive to building a new mega dams to reduce the frequency and intensity of the climate change. So my immediate response for this question, yes, government of Pakistan is on track, keeping in view the previous record of these natural calamities in Pakistan, building new dams, strengthening the Ministry of Climate Change, building a strong coordination with the national international partners to mitigate the impact of the climate change in the country. Over.
Thank you for that, Dr. Mukhtar. Very insightful comments there. Joe, do you have a question for Sergio, maybe?
Yes, yes. I think Sergio, a number of questions related to kind of spatial repellents and kind of terminology around spatial repellents. So, um, um, I think one of them it related to the kind of comparison and evaluation of spatial repellents, and understanding that there's a lot of kind of technical math instead of direct comparison of the situation and epidemiology of disease. So I'm just, I think in general, a lot of people are wondering, where are we moving in terms of the evaluation of spatial repellents now that they have an approved product within WHO? Where do you see that moving, especially as it relates to looking at the overall epidemiology of the situation rather than some of the kind of comparison models that were needed maybe for approval at WHO level?
Good. No, thanks. That's a very important point as well. Just for clarification, special repellents, special emanators, they have been used interchangeably. I think the manufacturers in general realize that special repellents may be, and we are facing that problem in places where we implement. People think that mosquitoes will be pushed outside their homes, when in fact that doesn't necessarily happen. So I think over time the name has evolved to spatial emanators as a way to kind of capture these dynamics. So again, the mode of action of these emanators is like a normal, I would say, coil that you put in. The big advantage is that it lasts for 1 year, the latest product. But basically, it repels mosquitoes, but also again interferes with their nervous system, and they are less likely to bite humans inside the houses. We mentioned the outside transmission earlier, so I'm not going to dive into that. To go straight into your question, I think there's a lot of test cases or use cases that are needed in terms of moving forward. We mentioned outdoor transmission. I think one of the main questions in the community now is can spatial repellents, spatial emanators, be used as a standalone tool? And I think that's the main question. Of course, there's a lot of ethical issues about what to use as a gold standard for protection in a control group, and how that then jeopardizes kind of the possibility of assessing spatial repellents as a standalone tool. The other end, I think there's also a question here is particularly in these conflict settings or complex emergencies, is how can this be integrated, these tools, because they are really light, easy to use, as I mentioned. How can they be integrated, for example, into existing packages of non-food items? Because one of the key points, one of the key issues in challenging environments is the speed of intervention. We know, in flooding settings, for example, we have 2 to 4 weeks to implement interventions. That's when biological, the mosquitoes lay their eggs hatch, and so on. So that's kind of the time frame we have when we're talking about shipping LLINs, or even procuring insecticides and materials for IRS. Unless the country has them in stock, then it's very hard to do those interventions on time. So can an intervention like special repellents be packed with other non-food items kits, for example? That's one area we are also kind of looking with the UNHCR in particular. Because again, in a camp setting where camps are set up very quickly with tents, we know the shelter size. It's very easy to pack with the tent packing. Also, some vector control interventions. So I think there's a lot of areas that need further research, aside from all the technical elements, quite entomologically kind of focus that we briefly discussed. But I agree with Dr. Leo that would require perhaps a 1 or 2 day full meeting just to go through what are the best methods to assess entomological outcomes or endpoints, because it's a different way of working this tool. So it really needs some thoughts on how that can be measured. Ultimately, what we are looking for is for epidemiological endpoints, and the results show some epidemiological impact, which is key. But I think in the vector control area, and entomologists in particular, they want to really understand how is this tool affecting mosquitoes as well, their behavior and so on. And sorry to mention mosquitoes only, but we should in my opinion, look beyond mosquitoes, because again, we also proved that it works against sandflies. So that's there's a lot of use cases for this tool. But I'll stop here. I mean, a lot of areas to continue research and build some evidence for then improving implementation. Thank you.
Yeah, thank you, Sergio. And it's great that mentors thinking about these other type of epidemiologic studies, especially as it relates to humanitarian settings and the proof that might be needed for them to be included in NFIs or other kind of humanitarian emergency kits, and that might be a barrier that some of the donors or other implementing partners need to see in order for them to be convinced that spatial emanators or repellents should be included in that. So very great to hear. Dr. Leo, I think back over to you maybe for Dr. II.
Yeah, thank you. Thank you, Sergio, and thank you, Joe. So I find myself having to hold myself back. It's so easy to, get involved in this very important new tool, new in inverted commas, the spatial emanators. And it's very much the flavor of the month currently. But no doubt, a very, very valuable new addition to the toolbox for vector control. Although WHO only approves or endorses the use of spatial emanators in conjunction with bed nets in indoor situations. And the same can be said for WHO will endorse larval source management in particular conditional situations, like there must be few, fixed, and findable. WHO will not, Global Fund will not pay for any of that. WHO says, okay, this is a proven, effective new tool. But, we're only going to support payment of LLINs. So if you want to do it, go ahead, but find your own money. So there are lots of challenges that still exist for that person sitting in the middle of nowhere in rural Africa or in the middle of the jungle that has hardly any disposable income. Can they afford IRS or, spatial repellents and so on? All of these are very important issues and questions. But let me move on to you, AA, if you don't mind. There's a question here, given that routine vector control, which is IRS and more specifically LLINs, and rigorous case management are already in place, what is the primary gap that's causing outbreaks or residual malaria, ongoing malaria, when we have vector control measures in place? Is it driven by population mobility, by insecticide resistance, or asymptomatic cases? Furthermore, what strategic shifts are needed to prevent these outbreaks? I'm going to throw in a separate question raised by Indra Vittilingam, also in the Q&A box. Does a zoonotic malaria, Plasmodium knowlesi, and there are a bunch of others, is it a significant additional contributor to malaria cases in the areas along the Thai-Myanmar border? So let me hand it over to you, if you want to venture a comment on that question, please.
Yeah, that is I will try my best to respond to the question. So that is not very easy to eliminate the malaria, because as I mentioned, our population is very mobile. And then also in the camp setting, it is actually practically, theoretically, they are not allowed to go out. But this is just a refugee right to work policy, just open in Thailand, issued by cabinet. And that is that. So most of the people, this is the reason why the male patient percentage is higher than female. So working age group men, they work outside the camp. And also they need to bring that they are personal protective measures along with them. And also they must know that they know, and also practice is also another important. So they need to wear the clothes and they have to use the bed nets and because many industries like rubber doubles and construction workers, and also they used to work in the jungle or forest. So they need to protect by themselves. Of course, that is that the funding is the main issue. And if they request the LLIN for us, for the intervention, if we see the positive case that we provide, even we do the mass LLIN distribution, depending on our criteria, if we see the positive case, we also provide LLIN. But practice, they must use that LLIN. That is very important. Second point is that for the Plasmodium virus positive cases, we need to compliance issue. We have to track the patient to complete the dose of the Primagon, something like that. And that is also very critical issue for community outreach workers. Sometimes we're going to track the patient at their house. They come again to our clinic with the problem of the problem of fever. So for in that setting, in our camp setting, so that we provide health education several times. That they've been staying in the camp for many decades, so they know very well how to prevent by themselves from the malaria. But it is the practice is one issue. So if they have fever, and also only fever, and about the history of fever within 72 hours, and also chase a Riga, whatever, they can come to the camp health facilities. They can do the blood test immediately. But maybe some people is that they don't mind, and also just stay at home, and they took some. They are taking some medication. Maybe that is also another factor. Just arrive to the clinic very late. But in terms of modality, it is that we can maintain the good. We don't have a malaria death case in the camp center for many years. But recently, it is one PV case. But that case we have underlying very severe medical condition, so that one case passed away. That is a history. So to respond to your question is that many factors are related. To eliminate is not easy. Multidisciplinary approach, community participation, and also that is funding, and also in collaboration with the Thai authority. I would say this is a camp study is not excluded. We can follow all the guideline instruction from the Thai authority. Our collaboration is, I would say, very good, but it's a community themselves also they need to participate, and also especially for the preventive measures. And yeah, that is main thing. So to complete the treatment for full course, and also they must follow, and that is very important. They must know that it's a kind of the event. We don't need to use that medical terminology in detail, but it's what is relapse. And so they should know why they need to follow that medication for 15 days. If they realize that real situation, not if they know the why they have to take that medicine, they are really happy to follow. So change attitude, behavior, knowledge, and practice, all the factors are related, plus funding, plus collaboration, cooperation, community leadership, participation, community empowerment. Many factors are related. Yeah, thank you very much.
Yeah, thank you. You addressed another question inadvertently during your response, a question by Dr. P.T. Joshi. Why was there a disproportionate number of males being infected? And you said because they are the ones that go out of the camp and pick it up outside the camp. Can I just ask you very quickly if you could respond to Indra Vitilingam's question about is zoonotic malaria a factor as far as you know? Are you picking up Plasmodium knowlesi or Cynomolgi or any other non-traditional Plasmodium species in your cases? It's not a significant factor. All right. Okay. Thank you. Very much appreciated. So I see we're going to allow one more question that Joe will pose to Dr. Mukhtar. We are starting to lose audience numbers fairly steadily now, which tells us we're overstaying our welcome. So, Joe, could I ask you to pose one more question to Dr. Mukhtar? and then we'll move on to the very short, brief poll survey for our audience to kind of score us. A very simple little survey. I ask our audience members, please, to be patient and just complete that little survey after the question to Dr. Mukhtar. Thank you so much, Joe and Dr. Mukhtar.
Yeah, Dr. Mukhtar, I think there's actually a couple questions about this, so I'll just ask the one, but I think it actually answers a few different questions for you. And I think one of the strategies you highlighted in your slides was on larval source management. So a number of people were wondering how this strategy has been implemented in Pakistan, particularly in areas where flooding is frequently reported. And is this strategy really effective in those flooding areas? So thanks.
You're on mute, Dr. Mukhtar.
Sorry. Thank you very much. Again, this is very interesting question. Yes, of course, the larval source management, despite the fact it's a supplementary intervention, but in certain scenarios, it can also affect like a core intervention. So in Pakistan, when we face this problem of the flooding and even in the routine setting, the larval source management has been the integral part of our national strategy at all the time. Particularly for the flood affected areas, we have some different strategies. Different strategy mean the use of the biocide as well, because previously we always focused that larviciding mean use of chemicals. But no, it's some innovations that the biocides are available, like BTI, spinocides are there, particularly in the flood situation, because you know that in our national strategy, the use of chemical in the flood water is highly discouraged. And this is evident that this year, when I personally, as a national program manager, went to some flood affected areas with some top level expert from WHO, it was hard for me to believe that I see thousands of mosquito fish in the flood water, which means that the nature was also playing its role to control the vector population. So we asked the community, even the provincial program, not to use the chemical in the flood water. Even it's not recommended that, because the flood water is a huge water bodies and it is not. The larviciding mean that in the small pockets, where the flood water accumulates in a small but manageable water bodies. So larval source management is a very effective and efficient part of our national strategy. In the scenario of the flood or the disaster, like, we only focus the small accessible water bodies, because sometimes you know that in rural areas the communities are very poor. Sometimes they use the flood water even for the drinking due to the shortage of water, due to some safe drinking water. So that's why the larviciding is extremely discouraged in the flood waters. We promote the biocides, but even biocide in the small but manageable places, not the across the stagnant water of the flood water. So this is a very effective strategy, not only for the control the mosquito population, but also for the safety of the local community. At the household level, of course, we educate the community to manage their water bodies, that the storage practice, for the improved water storage practices and the other practices which can be managed at the household level. So larval source management, right from the community up to household level, it's a part of national strategy and found very effective when it is implemented in its true spirit. I think I'll cover this. Yeah.
Yeah, Dr. Mukhtar, thank you so much. A very, very interesting answer, and very nice to highlight the kind of multi-sectoral approaches that this vector-borne disease, vector control tools within humanitarian emergencies have, and the connection that it has to wash activities and how people are ultimately utilizing water. And it's also very interesting to hear about Pakistan's use of biocides as well. I'm sure more people would be interested to hear about that. So, Dr. Leo, back over to you. Thank you.
Thank you, Joe, and thank you, Dr. Mukhtar. So What remains now is again to ask our audience, please hold on for a few more minutes just to help fill in that questionnaire. It's very short, very brief. It's not going to take up more than probably 1 minute of your time. May I also, I hope I'm reflecting your opinion, dear audience members. I found this an absolutely thoroughly enjoyable, highly informative webinar with 3 excellent presentations. So, for your participation, audience members from all over the globe, and sustained interest with high numbers staying in for most of the duration of this webinar. Sincere thank you for your interest. We hope to see you in our next webinar in a couple of months' time. And, it's made interesting and valuable by the quality of the presentations prepared by our expert 3 speakers. So from all of us, audience members, backroom boys, to Sergio, and Dr. Mukhtar, and also to Joe as a very effective co-moderator. To all of you, sincere thank you for your contributions, your valuable time. I would also like to thank Dr. Porn and Wulan for your technical support, unseen in the background, very important to make the webinar work. So to everyone, again, sincere expression of gratitude for all your contributions. You will see the poll on the screen there. You can just click and respond on the screen there. 3 questions, and it will help tell us if we're doing okay or we need to give more attention to particular aspects. Sincere thank you, everyone. Joe, I don't know whether you want to say goodbye to everyone. If you want to, floor is yours.
Thank you, Dr. Leo. I just want to thank you again and APMEN for including RBM and our task team on vector control and humanitarian emergencies. It's been a pleasure to work with you. We hope to be able to collaborate with you in the future. And also just a plug for those of you that are going to be at the RBM Vector Control Working Group meeting in Nairobi the first week of March. We will have a session on vector control and humanitarian emergencies with some excellent speakers presenting some new information and some new research that is coming out, as well as some operational adaptations. And then we hope to have a side session as well, where we'll be speaking to kind of bigger priorities and needs within the community as well. So I hope to see some of you all in Nairobi in March.
Thank you for that reminder, Joe, of the upcoming RBM VCWG annual meeting. A very important platform. Experts from all over the planet converging to share knowledge and information and perspectives. All right. So I think I'm going to shut down my ugly face on the screen, and I wish you all well. Hope you have a great day going forward. Thank you again, everyone.
Thank you.